So thank you very much to our speakers. We've run a little bit over time with the talks, but I think now is a good time really for questions. So can I open it up to the floor for anyone who would like to ask any of our speakers any questions? Oh, there you go. So we've got Noyat over there.
Thank you for wonderful talks. On the last case that was presented, I think it was Jan, I was wondering, did he understand that if he refused tube feeding, it would hasten his death? Was he able to understand that?
So yes, the answer was yes. Yeah? Yep.
And then I can say, yes, no. Yeah, he was able to understand it. And that was for the caregivers so much of a problem, because they thought, he is really there. It's not a person who's laying all the time in bed, don't react. And that's most of the time the natural cause of the disease. The caregivers can also adjust to the situation. And in his... he was cognitive, capable of saying what he wanted to do. Yeah, and that was very nice that his sister had a conversation with him. So, yeah.
Two very quick questions, if I may. Anytime ethics comes up and moral deliberation comes up, I give a very, very tiny quote of Aristotle, and he said, "We are what we repeatedly do. Excellence, therefore, is not an act, but a habit." And I would like to ask, for those who do implement moral deliberation into your daily care, how did you turn it from an act to a habit, so that the whole multidisciplinary team has the knowledge, knows how to implement moral deliberation into daily practice?
Okay. Thank you, Noit. That's a wonderful question. I'm going to ask Ruth if you will...
Well, thank you for the question. I think we discuss during ward visits, and we have a special behavioral visit, and we have multidisciplinary deliberations on the patient, and we discuss it quite a lot of times. And we have the advantage of knowing almost all our patients that in the nursing home during their first earlier stages of HD. So because we see them each year when they're at home, and then they come in the nursing home, we know who they are, what they live for, what they're coming out of their bed for, and what they don't want. And we discuss, even in our outpatient department, always advanced care planning. So we sort of live with them through the whole process. And our team, we have lots of discussions. And well, we managed to do it quite a lot of time, and we're not always successful, but I think we have some sort of way of doing multidisciplinary treatment and care. Yeah.
Dare to take a risk, maybe?
We dare to take a risk. Yes, of course we do, and sometimes we find out it's no good. But here are more questions.
So we've got a question at the back. I don't think the microphone's on. I don't think it's working. You have to shout.
So it's more of a comment about the talk about apathy. And
From Una.
I did a bit of research about it. One of the points I wanted to make, especially with the reward learning framework, learning positive and negative outcomes. So I did some work very pragmatic. Learning from negative surprise. So
Thank you. I think that's a really important point. I wonder whether Una wanted to speak to that. That was really one of the drivers behind us thinking about this session, I think. So perhaps Una can respond.
Yes, thank you very much. I think that the area of apathy is so big, and yet, as you say, we haven't got an awful lot known exactly of how it works, and also that there's also evidence to say that actually when the physical load increases, that the reward system doesn't work quite the same way as when the physical load is less in people with Huntington's disease. So there's all these things that are challenges to us and to all the healthcare professionals to try and work. But I think that the way forward is to maybe explore apathy more in the practical sense. There are no interventions that we know of yet that can actually help with apathy, and therefore I think that's the future of looking at this. Thank you so much.
Yeah, just very quickly, thanks. I just had a question for Margret. Thank you again for your talk. I was wondering, considering what you said about the need to have open conversations with patients and keeping in mind their desires, I was wondering whether those conversations also involved the need for changing nutritional behaviors early on, given that we know that there might be some hypermetabolism, some early weight loss in people with Huntington's, and we know from other conditions which have a much faster trajectory, like ALS, that there are very strong resistances at time when hypercaloric diet needs to be implemented, and we all live in a world that tells us that eating too much fat, eating hypercaloric diet is wrong. We've been told that our entire lives, and then all of a sudden people with these conditions, including Huntington's, are told, well, now you have to start eating loads of cake, you need to start eating as much fat and as many calories as you can because you are burning through calories. And people say, well, no, I don't want to do that. So I was wondering whether you have these kind of conversations in your clinical experiences.
Honestly said, all the way from the beginning when they come to our, how do you call poly in English? Outpatients? Clinical patients. Then we already discuss it. We gave the dietitian and the speech therapist are offering a book in which everything is described about feeding and what are the pros and the contras. And there is very clearly, it's also available in English, and then it's very clearly that it's important and why it's important to make such a switch from wiped cream on your dessert, which we don't have to do every time, and it's for them important to have a lot of calories. Yes, of course we find resistances, and then you have to accept them. But it's a little bit funny. Last week I heard that somebody didn't want all the stuff the dietitian offered, but because it was too sweet and it wasn't a good taste for this person. So I looked what she was eating, and she was decreasing in body weight, and it was normal because she didn't eat all the extras she had to. And then I saw that the caregivers were doing on the bread the kind of amount we would do. A little bit butter, a little bit of spread. And I said, no, butter, and much stuff on the bread. So, and she gained two ounces already. So, I hope. But is this the answer you want? Okay.
Okay. So I can't see anyone. Oh, I can see one more hand. I think this is going to be probably our last question, and then I'd encourage you to come and chat to our speakers some more about some of the kind of the points that they've raised. So,
thank you for all the useful information, and congratulations to all of you. I would like to ask something about the legislation, about the law. when the patient make this decision, is there any documents that sign about his decision? And if if he changed the decision, what happens about this change of decision legally?
Well, if I have your question correct, then there is a law in the Netherlands where people have to agree with what we as therapists offer them. And when they say, we won't do it, we as therapists have to accept that. So that's the basic law. When you go to a doctor, you get an advice or a therapy, and then you say, well, I do it or I don't do it. So the prohibition of therapies is leading in our law, and people may ask from us evidence-based medicine. That's what they can require, and quite a lot of times we don't have enough evidence to really say this is the best for you in your situation, but we know, of course we know quite a lot, but there are no legal issues in these tube feeding cases that are there. So that's all within, of course, always we work within legal boundaries. And we don't have a problem in that. Is that what you were asking?
Actually, if, for example, the family wants the patients to change the decision, the patient wants the tube, the family, the patient don't want the tube, the family wants the tube. The legislation supports the patient. This is a decision of the patient. You cannot interfere.
In that case, what I, as a doctor, should do, I should say whether my patient is cognitively well enough to express his wishes and whether I have to follow it. And in the Netherlands, we have a law which says I only have to judge whether the patient is cognitively able to decide in this particular situation. So, for instance, if we know that this patient has said that this for all of his life, then I can say, well, this is what he always wanted. How can we find what the family is dealing with in thinking that it should be otherwise? Because they know him also all of his life. So how can we find out? And sometimes it's difficult, but I almost never can't come out of that dilemmas with patients, because we always can sort of do a moral deliberation with them and see what's in for it for them, what's in for it for the patient, what are their guilt feelings about having a diseased a person, and aiming for quality of life and aiming for a long as possible life. And well, we can just discuss it. And actually, we never have, we have dilemmas, we have difficult discussions, and sometimes we have, especially with our citizens from non-Dutch origin, we can have real hard times because people, as Margret said, someone is drowning in his food, and the family still wants to give food, and that was a very hard decision. But actually, we always try to go in a sort of shared decision way to the end of life or to the extension with tools at our disposal. So. You should.
I think we're...
Yeah.
Okay. So thank you very much to our four speakers for the challenges and the kind of thinking and the discussion. And I think there's a break now. I think so. Thank you very much.